Hello, I'm Dr. Omar Bey, and this is A Moment in Medicine. Our focus is health, education, and wellness. Our goal is for each and every one of us to have that opportunity to grow old in good health. Welcome to our show. Well, we have a great show for you today, and before we get to the main topic, I just want to go over caring and sharing. I'll never stop talking about caring and sharing, because if you care for yourself, then you'll be healthy. And if you're healthy, guess what? You can inspire someone else to go to the doctor and be healthy in their right as well. So caring and sharing, don't forget it. Don't forget it. And thank you all for all the social media contacts, the emails. Oh goodness, obeyyourdoctor@gmail.com. The Facebook is just like, it's very, very exciting, and it's very busy right now. We're doing things like weight loss and doing health tips, and we're doing inspirational messages in the morning. So go to Obey Your Doctor Facebook. Hey, like us. Follow us. We're doing some exciting things on Facebook. Instagram as well. We're posting meals on Instagram, ways to lose weight, all that kind of stuff. So we're really trying to get interactive with you guys out in the audience so that you'll know what we're about, and we will know what you're about. Okay? And go to obeyyourdoctor.com. Check out the website. We're doing some good things there as well. A lot of educational material. Let's talk. Okay. Let's talk about something this show. It's called weight loss. And weight loss is so important. And the reason I feel it's so important, because if we could decrease, let me put it this way, if you're overweight, if you could decrease down close to your ideal body weight, you would decrease hypertension, diabetes, heart disease. There are so many diseases that would decrease if our weight was in better control. So weight loss plans, they must have three things as far as I'm concerned. Number one, it's mandatory that you commit. You must commit and be honest with yourself and say, I'm really going to cut back on my calories. You must eat foods that you enjoy, because if you don't, then what's going to happen is you're going to get disinterested in the weight loss plan, and you're going to quit. And quitting is not an option. The third is understanding that the weight loss for most of us is a lifelong problem. And the problem is weight, but it's a lifelong endeavor, I should say. So we should always be thinking about what we're eating, portions and choices to keep our weight under control. Very, very important. Well, let's get to the meat of the show tonight. Basically, it's a very important show. We're going to talk about breast cancer awareness. And I have the perfect person that has come here tonight to talk about it and give you insight as to the awareness of and what's going on as far as breast cancer in medicine as we speak about it in today's climate. Okay. The doctor's name is Dr. Luke Partika, and he is Chief of Breast Imaging and Intervention at Newark Beth Israel Medical Center. Dr. Partika, welcome to our show.
Dr. Bey, thank you very much for having me.
All right. Now, I was so interested in this topic that I did a little reading before I got here, believe it or not. I actually read, and I'm so proud of myself. And let me just tell you, I was so impressed with the facts. I'll just go over these few facts, and then we'll get into your aspect of how you treat this and how you diagnose breast cancer and what you do.
Wonderful.
The fact that breast cancer is the most common diagnosed cancer in women. Number one. Number two is that breast cancer is the second leading cause of death amongst women. Very interesting. Goodness. Also, I didn't know that breast cancer can also occur in men. It's not only in women. That was very unique to me. A lot of reasons at this particular time from the readings, we have a lot of reasons to be optimistic about breast cancer and what we can do for those patients that develop breast cancer. And in the last 30 years, great strides in early diagnosis, treatment, and reducing breast cancer deaths has occurred. Very, very interesting. So I'm going to ask you my favorite question. My favorite question of all is, what is breast cancer?
Okay. Well, that's a very interesting question. Very simply put, breast cancer is an uncontrolled growth of breast cells. Okay. And now, what causes that? So typically, within each and every cell in our body, there's a regulatory mechanism, a mechanism that basically tells the cell, this is the time you should grow, this is the time you should stop growing, this is when you should divide, and this is when you should stop dividing. And sometimes you can get mutations within that, within the genetics within these cells.
Okay, hold on. Mutation. Okay, tell a mutation. Give me an understanding of what a mutation is, just for the audience.
All right. So if you can imagine, there's a code that tells the cell how to function, and now there's an error in that code for one reason or another. There are many factors that can cause these errors, but once you get one of those errors, basically what happens is now the cells lose their normal abilities to control their division and to control their growth.
Right.
And then we develop a cancer.
Okay. Excellent. Excellent explanation. Now, can cancer in the breast, can it occur anywhere in the breast, or is it usually in one specific place or something like that?
Well, when you look at the breast as a whole, it can actually occur anywhere, even in the nipple and the areola. So cancer can actually happen anywhere in the breast. But there are specific areas in the sort of microanatomy of the breast where it tends to happen more frequently. So usually it happens within the ducts. Now, if we look at the breast as a whole, the breast is typically composed of three things. The majority of the breast is actually composed of fatty tissue, but there are also glands and ducts. So when a woman gives birth, the glands are what produce the breast milk. And the ducts are sort of the tubing, the network that takes that breast milk down to the nipple for breastfeeding. The majority of breast cancer actually happens in the smallest ducts. We call those the terminal ducts. And that's the majority of breast cancers will occur in that location.
Alrighty. Now, do breast cancers usually go to other parts of the body, or do they stay there for a while, and that's why one of the reasons we try to do early detection? Give me an understanding.
They do. Well, in short, if left untreated, breast cancer will go to other parts of the body. Remember, these cells have lost their control mechanism, right? So they're just going to keep growing, dividing, until a point where they're going to enter the lymphatic system or the bloodstream and spread to other areas of the body. So breast cancer, in its early stages, is just localized to the breast. And that's really when we want to detect it. We want to get that early detection before it has spread to other areas of the body. We know that survival from breast cancer, as you already mentioned in your introduction, is actually very, very good if you detect breast cancer early. However, if the breast cancer has spread to other areas of the body, for example, the bones or the liver, we know that the survival odds are much worse at that stage.
Okay, alrighty. Is there a certain age that is more common to develop breast cancer?
That's another fantastic question. We know that age is actually one of the most important risk factors for breast cancer. So typically, breast cancer is a disease of adult and elderly women. However, we have gotten breast cancers diagnosed as early as women in their teens. It's very uncommon, but it does happen. But typically, the normal screening recommendations say begin at age 40. There's nothing actually magical about the age 40. It just happens to be what was chosen in all the trials that were done. However, as a woman gets older, the theory is that the longer you're alive, the higher the chance that one of these cells is going to develop one of these mutations and you'll develop breast cancer.
Oh, goodness. Now, what about as far as race? Is one race more prone than another race as far as this is concerned?
So for example, if you take a look at white women and African American women, the rate of the risk of developing a breast cancer is actually lower in African American women. However, we also know that the death rate from breast cancer is higher in African American women. And a lot of that, it goes back to historical, lack of access to really good quality mammography screening and good quality medicine, which I can tell you here in Newark we don't have that problem. We have great technology, and really it's about now patient education and getting the word out there that we have great treatments for breast cancer, especially if we find it early.
So early detection is it, and to test for it early. That's correct. Don't be afraid. I would imagine that in certain communities, they may be afraid to go get the test.
That's right.
In other communities, because going to the doctor is not something that they do on a regular basis, they may not get the test. But it's something that should, we should think about. We should get that education out there.
That's right. And Dr. Bay, actually, one of the most common things I hear from patients is, I rather not know. I rather not know. And that's really unfortunate, because if you do know and you know early, that your chances of surviving that and living to a ripe old age are fantastic, actually. Excellent. And I think if more patients knew that, they would be less afraid to come and find out that maybe there is a tiny little lump, and maybe we can get rid of it, and they can live, a very healthy life for a long time.
Okay, alrighty. Family history. Mother had breast cancer, maybe grandmother had breast cancer. Now I'm looking at it and wow, am I going to get it as well?
So a few interesting things about family history. So if one of your first degree relatives, that is your mom or your sister, has had breast cancer, your risk of developing breast cancer is actually double of a woman who doesn't have that risk factor.
Okay.
And likewise, if you have more than 2 or more first degree relatives that have had breast cancer, that risk continues to increase. So you might see a 3 or 4 times the increased risk of breast cancer over a woman who doesn't have those risk factors.
All right.
Now, the important thing to mention here is that despite that fact that family history is such an important risk factor, the overwhelming majority of the cancers we see are actually sporadic cancers, meaning there's no family history there. So 85% of the cancers we diagnose, the patients don't actually have a family history of breast cancer. And it's interesting because they say, Doc, how did this happen? No one in my family has ever had breast cancer. And so that's one of the common misconceptions, is that breast cancer only develops if you've had a family history.
Wow, that's a very, very important point that you just made there. Alrighty. Now, I know, and I want to get to this aspect of our talk, early detection, because I just think that patient education is just so important, and especially in certain communities, it may be the African American community, the Spanish community, or whichever community that, healthcare is just not one of the things that, that is focused on. In the family, there's so many other issues of the family, it may not be focused. It's so important for them to understand the patient education and to come in for the test. Tell me, and I understand that this is what you do. You do the imaging, you do the diagnostic.
That's right.
Tell us about what you do and how you do it.
Wonderful. So the majority of women that come into our center are coming in for screening, okay?
Right.
That is, they don't have any symptoms, and they're just coming for a mammogram. So a mammogram is basically a low-dose X-ray of the breast. So if you've ever had a chest X-ray, it's essentially the same thing, except it's done on the breast. Right. Okay, and we can get into a little bit of how the mammogram is done shortly. Now, if we see something on this mammogram, we will recall the patient back to do some additional views, to maybe do an ultrasound, which is another investigational tool that we use to narrow down a possibilities of whether the abnormality could be a cancer or not. Right. And then finally, if we decide that there is indeed a finding that is suspicious, and then we would do something called a biopsy, which is essentially taking a very small tissue sample from the area and figuring out, is it really a cancer? Right. So it's a minimally invasive way, a way where we don't actually have to send the patient to surgery, and we can do the procedure under local anesthesia, and we can get an answer that way.
Okay. So when you say local anesthesia, you mean just numbing the area?
That's right. Okay. We just give numbing to that one particular area, right. And actually the procedure is not very uncomfortable at all, actually. Okay. Beyond the initial numbing, really the patients say they don't feel absolutely anything.
All right.
And then, like I said, that's a really good way for us to get to the actual answer, rather than sending a patient, for example, to the operating room, where there's obviously a higher risk associated with that, and also there's scarring. We have virtually no scarring in the breast when we do this.
Excellent, excellent. Now, I have patients that come through sometimes, and not often, but every once in a while I'll see a mammogram, and we're going over her mammogram if the primary doctor has sent it to me because of something in the lung or whatever. And several patients have mentioned that it's quite uncomfortable to have a mammogram. Explain this, because I think we need to let them know that
That's right.
it's not as well. I shouldn't say that. Well, explain it to us.
So, you know, having a mammogram is somewhat uncomfortable. There's no doubt about that.
Okay.
You know, a lot of patients ask, is there not a different technology we can use?
Right.
Well, the important thing to stress is mammography is one of the most studied medical interventions that we have in our time, and it has consistently shown that we decrease the rate of death from breast cancer by 30%.
Wow.
Okay. Now, there is a little bit of discomfort associated with it. Now, why is that? Because we compress the breast. Okay. So the way a mammogram is done is the breast is placed on an image detector, and then a compression paddle comes down and compresses the breast.
Right.
Now, there are certain ways to mitigate that discomfort, and our technologists are trained to do the compression very slowly, very gently, and to really be attentive to the patient to make sure that the patient isn't having too much discomfort. Because really the point of the mammogram, of course, is not to hurt the patient.
Right.
The point of the mammogram is for us to be able to find a cancer when it's early and when it's more treatable. Right. So there are some ways that the technologists can really help diminish the discomfort associated with doing the mammogram.
Okay. How often should you do a mammogram?
So there's a lot of controversy surrounding this topic, as you may have heard. We have always recommended and continue to recommend screening once a year, every single year, beginning at age 40.
Right.
And now if you have a first-degree relative who has had breast cancer, then not only should you screen beginning at age 40, you should actually start a little bit earlier. You should start 10 years before the age that the relative was diagnosed with breast cancer. So for example, if you have a mom who was diagnosed with breast cancer at age 42, you should begin screening at age 32 with mammography.
Right, right. Okay, then. And you said that you start, if there's no history of breast cancer in the family, you would start at 40 years old.
Correct. Age 40 and every single year.
All righty. Tell me about self-exam. When should you start it? How often it should be done? And how do you teach patients to do it appropriately?
Okay. So self-breast exam is also has been a little bit controversial recently, because some societies have come out and stated that maybe self-breast exam is not as effective as we previously thought.
Right.
However, I, Dr. Bey, continue to recommend self-breast exams, and I'll tell you exactly why. Every single year, I get many, many women. Some of them are too young to have began screening mammograms, or some of them, happen to have missed one year, and they feel a lump on their own, and they come in and they say, "I have this lump. Can you please evaluate this and tell me what it is?" And we find many, many cancers that way, actually. So I always tell all the patients when they ask me about self-breast exams, I say the day I will stop recommending them is the day that the patients stop coming to me having found their own cancers.
Right.
And we know that day is not coming, so I'm going to continue recommending them.
Right.
Now, when should they start? So typically we would recommend that a woman starts her self-breast exams at age 20 and performs one once a month, and does that beginning at age 20 on a regular basis. That way the woman learns what her breasts feel like, what the normal breast architecture is like, and then that way if there is an abnormality in the future, the woman is able to detect that sooner.
Alrighty, okay. Now, you were talking about the ultrasound. I think you stated it was an ultrasound that you do. What exactly is the ultrasound? Explain the ultrasound to me.
Okay. The ultrasound is a fantastic examination. We're actually beginning to screen some patients with ultrasound. Historically and traditionally, the ultrasound has been a diagnostic tool for us. So what that means is if there's an abnormality on the initial screening mammogram, we would bring the patient in and do the ultrasound. Now, the ultrasound exam itself, what it is in comparison with the mammogram, it's completely painless. What it is we use a camera that uses sound waves, and those sound waves are basically beamed into the breast and then are beamed back to the camera and result in an image being formed on our screen. And now those sound waves travel at different speeds through different tissues, through fat, through liquid, and through solid masses. And so we're able to see actually on a black and white image which areas are abnormal on the ultrasound. Now, as I mentioned, the exam is completely painless. What it is a little bit of gel is applied to the breast, and then the camera is just scanned over the breast in a systematic fashion, looking for abnormalities.
Alrighty. Now, at your unit, is it required for the primary care doctor to refer the patient over, or can a patient just walk in and get the test done?
So for screening mammograms, we take walk-in patients.
Okay.
We prefer the patients to come in with a script because ultimately we need to send a report to a physician.
Back,
and
yeah.
that goes, we also notify the patient, of course, of the results. But sometimes, if the address is not correct, we want to make sure that this patient gets taken care of should we discover something on the mammogram. And having a prescription from a referring physician allows us to do that. However, we do take walk-in patients even without a prescription for screenings.
Alrighty. Are there any other tests that you do for screening other than the ultrasound, the self-exam, and the mammogram?
Yeah, for certain patients who have a particularly high risk of breast cancer, we would consider doing a breast MRI. Okay.
Now MRI is that one that you're all closed in.
That's right.
That's right. And you are
you're kind of
claustrophobic type thing.
So some patients have a little bit of trouble with it. There are some open MRIs out there, but typically it is the exam where you slide into the donut.
Right.
The good thing about the breast MRI is actually the patient's head does not go into the donut.
Excellent.
So actually you feel you don't feel that sense of claustrophobia as much with the breast MRI. But basically for certain patients who would have a really high risk of breast cancer, we would recommend doing an MRI because that's really the most sensitive exam. It's going to pick up the most cancers.
Okay. Now, do most of the patients that come to you, do you find the cancers early? Is that how it usually goes, or are we still working at that? A lot of cancers are coming in late, diagnosed late.
Right. So it's interesting because we are making great strides in this regard, especially at our institution. A lot of patients, when I first started, were coming in with late-stage disease,
right?
And that still happens. However, what we're doing with mammography, we are detecting the cancer much earlier. So now we're seeing that the stage of our cancers is actually shifting. And the important thing to note here is that the patients that we detect early are the patients who come in for those yearly mammograms, the patients who come every single year and really don't skip any. Those are the ones where we detect that very subtle change in the mammogram, and then we're able to work that patient up.
Okay. Tell me about the biopsy part of it. Okay. Describe a patient coming in for biopsy and what you would actually do to get that biopsy done.
So basically, the goal of the biopsy is to get a tissue sample.
Right.
So now you can imagine we've done the mammogram, we've done the ultrasound, and we've located a lump that we think could potentially be cancerous.
Right.
So what we're going to do now, that patient's going to come in, and typically the biopsy is done under ultrasound guidance. So this goes back to we place a little bit of gel on the breast, we place the ultrasound camera on the breast, which is completely painless, and then what we do is we give, as we had mentioned earlier, some local anesthetic. Okay. Now that local anesthetic is given through a very small needle. There is a little bit of discomfort associated with it, but the medication that we use to numb the breast is very fast acting. So typically in about 15 seconds, the patient doesn't really feel any discomfort. And now that we have the breast completely numb, we use our ultrasound machine to show us exactly where our needle is going. And what we do is we insert the needle right into the center of that lump, and we press a little button on the device, and it takes a little sample out, and then we just remove that tissue out and we send that off to the lab.
Okay, alrighty. And how long does that take to get back to you the results and stuff like that? How long does the patient have to usually wait?
So the good news about the biopsy is it goes very quickly. The biopsy actually takes less than 5 minutes to do. Okay.
Excellent.
And then typically it takes about 3 days to get the results.
Okay.
And that varies just based on how busy the pathology department is. But usually about 3 days to get the result.
Okay. And if it's negative, then what do? Do we just do mammograms every year still, or is there some special procedure because there possibly is a lump? You know what I mean? It could turn cancerous in the future. How do we handle that?
Yeah. So if the result comes back benign and we're happy with that result, meaning that
benign means that no cancer.
No cancer.
Okay.
Correct.
Okay.
So if the result comes back no cancer, and we are okay with that result, meaning we sampled the lesion well, and we think that the lesion, the way it looks, there's a possibility that it's benign, meaning we say that's concordant, meaning we got from the pathology is possible, because sometimes we do have discordant results. But if everything is great, then we see you back in 1 year for your mammogram, and we just continue to follow you that way.
Okay. What if it's positive? Where do we go?
So if it's positive, which unfortunately does happen in a percentage of cases, what we typically do is we're going to refer the patient to a breast surgeon. Okay. We have a navigator at our breast center that helps the patient navigate through the whole system. The patient will start with us. We'll meet the navigator prior to the biopsy. And then if the biopsy were to come back positive, the navigator helps refer to one of our breast surgeons. And then we have a multidisciplinary tumor board at our hospital that discusses every single positive case. And it's a group of doctors from various subspecialties: oncology, radiation, surgery, radiology, pathology. We all get together and we present every single cancer patient. And we come up with a multidisciplinary team plan of how we're going to help this patient get to the desired outcome, that is removal of the cancer and a permanent cure.
Excellent, excellent. Now, tell me about, as far as, and we're narrowing down, we only have about a minute left.
Okay.
Tell me about estrogen and the increased possibility of breast cancer because you may have a lot of estrogen around. I was reading something about that.
Right. So with estrogen, we know estrogen is, although it is a normal hormone in the body, it is one of the culprits that increases your risk of breast cancer. So things that increase estrogen in the body are going to increase your risk of breast cancer. So for example, early onset of menstruation, late onset of menopause, delayed childbirth. These are all things that lead to the woman being exposed to extra estrogens. Okay. Additionally, and especially in postmenopausal women, obesity is a problem. You discussed weight loss earlier, and one of the things that we do know is that the fatty tissues will store a lot of estrogen, and that also leads to an increased risk of breast cancer.
Boy, oh boy! Now, this was a great topic, and I trust we had more time to talk about it. It's been wonderful having you here. Excellent, excellent explanations. And we're going to have to get you back and talk more about this and other topics, I'm sure.
Wonderful.
All righty. Thank you very much for
You're
taking time out of your busy schedule and coming and talking about breast cancer.
Thank you for having me.
Yes. Well, in closing, remember, caring and sharing. Take care of yourself, guys. Go to your doctor. Make sure that you take care of, if it's hypertension or diabetes or heart disease, take your medicine as you should. And make sure that you follow up and make sure that you don't have side effects or any other thing that may be, occurring during your medical care. Alrighty? Never institute any change in your medical care until you consult your physician. I trust each and every one of you continued good health. I'm Dr. Omar Bey, and this is A Moment in Medicine. Until next time, peace to you all.